Hello and welcome. The count of cases on COVID-19 continues to rise, but overall there seems to be a managing of the situation. But more importantly, the lockdown that we have been under now for in some parts of the country for almost 40 days is set to lift. It may not lift in the same way everywhere, but it's definitely likely to change from the 4th of May, which is obviously coming up. Now, the question as we go into it and we want to talk about getting back to work is, what are the big public health challenges ahead? Can we manage this transition from a lockdown to a regular life? And will, more importantly, life ever be regular again? So to answer these questions, I'm joined by Professor and Dr. K. Srinath Reddy, the President of the Public Health Foundation of India, formerly the Head of Department of Cardiology at the All India Institute of Medical Sciences, also serves as an adjunct professor of epidemiology at Harvard. Professor and Dr. Reddy, thank you very much for joining us.
Thank you.
Right. So, Dr. Reddy, I think the first question really very simply is, can I get back, or can I even think about getting back to work on the 4th of May?
Well, it depends upon which zone in India you're living in. If you're living in a red zone, then your movements are going to be greatly restricted. If you're living in a green zone, then certainly you can get back to work. But even in a red zone, a number of areas of work are likely to be resumed, but with great deal of care. The important element is that a lockdown is an extreme form of isolation. Now, when you get back to a post-lockdown phase, then you're going to be in a sort of self-imposed discipline of social distancing, or better called physical distancing, plus personal hygiene, which means hand washing and possibly masks. So the important thing is, if you're in a zone where the intensity of the viral transmission is considered to be low, the restrictions are going to be less in the nature of occupations, though some of these other restrictions will continue to be there. On the other hand, if you are in a high intensity zone, the nature of occupations that are going to be permitted will probably be less and be restricted only to the very essential ones. And as the intensity comes down, that list will grow, and possibly people can ease back into more areas of work and social activity.
Right. So then let me give you some data points. I'm sitting in Mumbai, which has, of the 35,000 cases that we have seen so far, 7,000 cases. In the state of Maharashtra, which has 10,000 cases. And the other maybe interesting insight that seems to be now emerging is that almost 78% of those who have died had comorbidities, but equally a large percentage of people, almost 49%, are now young, as opposed to maybe a much lower percentage earlier. So things are fundamentally changing. And not only is it getting localized, as you pointed out, and therefore where I am right now is a hotspot within a hotspot, but also the nature of the disease and the way it spread in the last month seems to have changed.
Well, we'll have to differentiate between the people who died and the people who are getting infected. And secondly, when we talk about rates, it's very important for us to recognize that a rate is essentially the number of persons diagnosed as a fraction of the number of tests performed. If you're going to be increasing the number of tests, then obviously you're going to detect more cases, and you always need to compare the ratio rather than just look at the number of cases that are being reported. Having said that, it is not unusual for young people to get infected, because they're usually more socially mobile. But in general, the clinical severity is much less, and fatal outcomes are very, very uncommon unless they have coexisting disease, or unless they have had marked repetitive exposure to the virus. That's why we are seeing sometimes, unfortunately, some of the younger healthcare providers also having serious infections because of the repetitive exposure part of it. But by and large, it is the older people and the people with comorbidities who are affected.
Right. So you talked about the proportion, right? So in India, we are seeing somewhere between 4.5 and 5% as the proportion of positives to tests. Is that a figure that you feel reflects the true picture?
Well, we do not really know, because these are based upon the kind of tests that have been performed and the indications for the tests. Now, people are beginning to recognize that there are a large number of asymptomatic people who might not have been tested. In other countries, we are seeing that when you're applying the antibody tests, which of course do have some false positives, or if you're even applying the antigen test much more widely, then you're seeing a fair number of asymptomatic people. Even in the ICMR series, there was a large fraction of people who were asymptomatic, at least at the time of testing. So if there are a large number of people who have been infected but never been detected to be so, then the percentages would change, obviously. So I believe overall, when all the data are in, we will find that this highly infectious virus has been less virulent than has been feared. And the main fear has arisen because of the rapidity of spread, which resulted in a huge surge of cases at once. But whenever it's all done and over with, we'll be able to get all the data, and then we'll be able to say, okay, it was not as bad as feared, but it did hit us with a suddenness that we could not cope with.
Right. So, I was interviewing Professor Jay Bhattacharya at Stanford and a week before last. And I mean, he, I don't know if you know, but he has been amongst those who've been arguing that the spread of this disease has been far wider than what we believe. So if that is the case, and that's in the US, of course, but if that's the case or likely to be the case, how should we in India interpret that as we get back to or try to get back to work?
Yes, I agree with that. The virus is likely to have spread far more. The US, of course, did antibody testing, and that has its own false positives. I would not entirely go by those numbers that came from California. However, I believe that certainly the virus does spread much faster and much wider than we are currently figuring it out in India. However, most of these are likely to be asymptomatic or mildly symptomatic. We can get back to work, but still, in order to protect ourselves, protect others, we do need to keep our physical distancing, masks, and hand washing, because we don't want to carry the virus back, even if we are relatively untouched in terms of physical effects. We don't want people who are older, people who are having comorbidities to succumb because we were careless.
So I'm going to come to the curve in a moment, but what do you, I mean, intuitively or clinically understand or have concluded from this disease and its spread so far, and the manner in which it has manifested itself in patients in India? So the question is, are we likely more immune than maybe other parts of the world? Are we experiencing a different strain of this virus? Or is there some other factor like maybe temperature, which is causing it to be is diminished in its efficacy? Are there any other factors that are at work or likely at work?
I believe, firstly, our demography has been our great asset. Firstly, we have a much younger population. Secondly, we also have a rural population where the mobility is much less. The transmission of the virus from foreign return travelers or their immediate contacts is much less. And therefore, unless we allow for a huge amount of urban travel to rural areas or rural travel to urban areas, you're not going to see the virus spread very widely in the rural areas. So that's going to be a large protected area. You can't just apply statistics from Italy or from China to the entire Indian population without taking into account this demographic fact. The second is, I believe also we have some benefit of advantage in terms of the temperature. The weather is probably likely to play in our favor, particularly as the temperatures rise and even humidity sets in. Whether the other factors like BCG immunization, malaria endemicity, polio immunization, which also has been recently invoked as a general immunity booster, whether these are operating or not, we cannot really say with confidence. All we can say is that these are hypotheses that can be examined. They're not evidence at the moment. They're hypothesis generating, but not hypothesis testing. Certainly, as far as BCG is concerned, some trials have started globally and also in India. some studies have been initiated.
Right. So to come back to the curve question now, or come to the curve question. So is this a flattening or blunting of the curve?
Well, as I said, you can really talk about the shape of the curve when you standardize for the number of tests that are being performed and for the criteria for the performing the test. If your criteria are expanding, or if your numbers of tests are expanding, naturally you're going to be detecting more. So unless you standardize for that, you really can't comment about the curve. But having said that, with the criteria becoming more liberal and more tests being performed, if we are seeing the doubling time actually widening and the curve actually moving to a lower slope, I believe that's a positive sign.
Right. So, I mean, just to quiz you again on the getting back to work part. So, even if let's say, okay, maybe I'm in a red zone, things are likely to be stretched for a little longer. But for those who aren't, they have to be mentally ready for the fact that they will be exposed to the virus and quite likely will contract it. Because to that extent, what has really changed in the last 1 month, except from the fact that we are obviously more prepared to handle this challenge than we were earlier?
Firstly, our health system is better prepared. To some extent, our social systems are better prepared. Thirdly, we are a little better prepared. I believe that lockdown is a form of imposed discipline, pretty severe at that. But now we have to move into a lot of personal discipline. It is something that we have to actually adopt as a matter of daily routine for some time to come. So even in the green zone, that's what's changing. So while we may be getting back to work, the way we work with our colleagues in the office, the way we move on the streets, all of this is going to change. And this is, I think, a time where we have been prepared for that change.
Right. And I'm going to come to questions on tuberculosis in a moment, because I know that's another area which you will return to with more emphasis later, because you have been working on in the past. Now, vaccines. There is a lot of research going on. There is one Indian company which is saying that something is likely to be ready by October. How are you looking at all the headlines from that world?
You're looking at medicines or vaccines?
Vaccines. Yeah, I'll come to medicines as well.
Okay, vaccines, certainly, I believe that the company in Oxford, actually I wouldn't say company, the group of researchers in Oxford are saying that they will have a vaccine available by September. Of course, the trials which we just started first have to show efficacy and safety. Assuming that they do, now manufacturers are already getting ready for large-scale manufacture. We know one Indian manufacturer, Serum Institute, which has already placed advance payments for getting access to the vaccine and preparing for several million doses of the vaccine. So there are, of course, going to be a number of other global competitors who are also racing towards vaccine preparation. If we are lucky, we'll get a vaccine available and tested by September. But even then, mass production and dissemination across the world, particularly in view of the kind of global demand that we'll have, means that we'll probably take about a year. Of course, if we actually get the manufacturing rights, because we have a great potential, we can produce at low cost, at high volume, then it's possible that even earlier than that, our population may actually stand to benefit. But I think we should plan for about a year before we see mass immunization.
So, one of the criticisms, Dr. Reddy, seems to be that, vaccines may come out, but if you look at what happened during AIDS, for instance, there were a lot of vaccines which emerged or looked like they'd emerged, but didn't finally work. And obviously that caused a lot of, let's say, expectation, and that expectation was dashed. Are people ready for that? Because it's the hit and miss. I mean, there has to be a hit and miss in this, which maybe people are not prepared for, even when it comes to COVID.
Obviously, when there is a fair amount of panic and apprehension about something that was projected as a mass killer, people have high hopes and look forward to a savior. we have to be ready when we are coming to actually experimental biology in the area of vaccinology, that we may have some failures. But right now, at least the Oxford team seems fairly confident, based on their prior work with coronaviruses, that they have a winner at hand. We'll have to wait and see. But fortunately for us, now there are at least 2 Chinese trials going on, 2 trials going on in Europe, and then also some trials going on in the US, and some vaccine development efforts have been initiated in India as well. Therefore, we are going to have several candidates coming up in the next a few months, and possibly the trials being completed over the course of the next 1 year. So we should hope for at least one of them to be turning out to be a winner.
So let me ask you this the same question a little differently. As someone, I mean, as almost a global public health professional, are you getting a sense that the momentum that we are seeing behind it, and we are seeing, compared to maybe, let's say, the Ebola or the SARS virus, that there is so much, sheer brain power and engine power going into this, that some solution must emerge? Only because we are putting in so much effort, and it should convert very soon.
Yes, I think that's because the West has never been threatened like this as ever before. Other than HIV, where also they managed fairly well early on, most of the other large epidemics, zoonotic epidemics in particular, have hit other parts of the world. This level of zoonotic epidemics with such surges in the infections and hospitals being flooded with cases, ventilators not being available, the West has never seen this in so many years. So there's a fair amount of money as well as brain power being put behind this effort. It is that level of vulnerability that has shaken them to the core. And therefore, we are going to see a much more intense effort than in the area of neglected tropical diseases, for example.
Right. Yes. And that's an important point to, I guess, behold for us. Now, on medicines, Dr. Reddy, so there are, again, I know the Indian Council of Medical Research has, prescribed an approach. Most doctors across the country are following that approach of using, let's say, hydroxychloroquine or retrovirals, virals, and maybe steroids, depending on the condition of the patient. But what's your sense on what our current medicine and medical approach is, and or it's not necessarily us, but let's say the global approach is, and could there be some sort of medical, I think cure is too positive a word, but some sort of positive intervention?
Well, a lot of trials are going on with a number of candidate drugs. At the moment, a lot of trials are going on with a number of candidate drugs in different parts of the world for treatment as well as for prevention. Now, in terms of treatment, it depends upon whether you have a properly randomized trial or not. That means whether you have a proper comparison arm. Secondly, what are the outcome measures? Are you going to be only looking at the viral load, or are you going to be looking at deaths, or are you going to be looking at the days to recovery from a very severe pulmonary or other infection? So the whole idea is to try and get drugs which are likely to be reducing the number of deaths with a clear-cut impact on mortality. Next, at least in terms of having a clear-cut impact on reducing the severity of the illness in terms of reducing the time taken for recovery. If you're only looking at the viral load, you may be misled. Now, therefore, the trials which have to be large enough in order to actually assess this, and that's why the WHO Global Solidarity Trial is looking at different arms, but hoping for sample sizes which are large enough from across the countries so that these very definitive hard endpoints can be assessed. Now, there have been a couple of trials that have come up in the last couple of days, in which one is they've looked at a particular antiviral drug, remdesivir, where they've looked at whether a 5-day course is adequate as good as a 10-day course, but that doesn't have a comparison arm. It's only looking at the duration. And it doesn't tell you whether the deaths would have been lower or something compared to some other drug or no drug at all. Then there's another trial which has actually been publicized with much larger numbers, where the same drug in a randomized control trial has shown that it is actually having an impact on reducing the number of days of severe illness. But it did not show any impact on the deaths because possibly the numbers were not large enough. So we do have several questions still to be answered. And that's why you need the kind of studies that are being done under WHO with a large enough number of patients recruited from across the world so that we can provide more definitive answers rather than providing half answers and half questions unanswered.
Right. Dr. Reddy, last question. As we get back to work or want to get back to work, your advice to citizens, public health professionals, and or medical professionals that will watch this?
Well, we are so used to moving around freely and having fun and frolic apart from everything else. We can still do that, but in different ways. I think we have to recognize that there are three elements of protection that are required. One is the physical distancing, second is masks, and third is hand hygiene. We have to maintain this for quite some time in public. At least the masks are going to be required. And that is necessary not only to protect ourselves, but to protect our colleague workers as well as our family members. So a certain degree of self-enforced discipline is going to be required. But that doesn't mean that we should not socialize with others in the best possible manner. It is not, something that we have to live with a doomsday scenario all the time. I think we should have that fun. We should have the socializing and reducing the social disconnect, but we do it in a different way. In fact, we commune with the nature also much more intimately now. We hear the bird calls, we have the visitors to our backyards. So there is so much to do. And if nothing else, being in Delhi and Gurgaon, seeing the blue sky and with breathing unpolluted air is such a boon that sometimes this doesn't seem like a punishment at all.
Right. Dr. Reddy, that's a really optimistic and positive note to end on. Let's hope we adjust to this new normal, and the new normal also becomes the normal in a way that things work out well for all of us, including, of course, nature. Thank you very much for speaking with us.
Thank you. Thank you.